Welcome to today's video where we'll be exploring a rare but significant endocrine tumor affecting the digestive system, glucagonoma. We'll delve into what it is, what causes it, how it affects the body, and the available treatment options. Understanding glucagonoma is crucial for early diagnosis and improved patient outcomes. So, what exactly causes glucagonoma? Glucagonomas are neuroendocrine tumors that develop from the alpha cells of the pancreas. These alpha cells are responsible for producing glucagon, a hormone that raises blood sugar levels. The exact reason why these cells transform into tumors remains largely unknown. However, in some instances, glucagonomas are associated with genetic conditions like multiple endocrine neoplasia type 1 or NN1. In most cases, though, they appear sporadically, meaning they arise without a known genetic predisposition. Research is ongoing to uncover the specific molecular mechanisms that drive the formation of these tumors. Now, let's understand the pathophysiology, or how glucagonoma affects the body. As the tumor grows, it secretes excessive amounts of glucagon. This excess glucagon triggers a cascade of metabolic effects. Firstly, it stimulates the liver to produce glucose, leading to elevated blood sugar levels, often resulting in diabetes or glucose intolerance. Secondly, the high glucagon levels break down proteins and fats, causing weight loss and a characteristic skin rash called necrolytic migratory erythema, or ME. This rash is thought to be caused by the depletion of amino acids and zinc due to the tumor's activity. The combination of these effects significantly disrupts the body's metabolic balance. Glucagonoma is a relatively rare disease. Estimates suggest that it affects around 1 in 20 million people. Because of its rarity, accurate epidemiological data is limited. It typically presents in individuals between the ages of 40 and 70, with men and women being affected equally. Due to the often non-specific nature of its symptoms, diagnosis can often be delayed, contributing to the challenges in gathering precise epidemiological information. The signs and symptoms of glucagonoma can be varied, making early diagnosis challenging. The most characteristic symptom is necrolytic migratory erythema, the distinctive skin rash. This rash often begins as small, red, itchy patches that blister and eventually crust over, typically appearing on the face, groin, and extremities. Other common symptoms include mild diabetes or glucose intolerance, significant weight loss, diarrhea, abdominal pain, anemia, and depression. Some patients may also experience blood clots, known as deep vein thrombosis, or pulmonary embolism. Recognizing these symptoms, especially the skin rash in combination with other signs, is crucial for prompting further investigation. Diagnosing glucagonoma requires a multi-pronged approach. The initial step involves a thorough medical history and physical examination, paying close attention to the characteristic skin rash. Blood tests are essential to measure glucagon levels, which are typically significantly elevated in patients with glucagonoma. Imaging studies, such as CT scans, MRI scans, or somatostatin receptor scintigraphy, also known as octreoscan, are used to locate the tumor within the pancreas and assess whether it has spread to other parts of the body. A biopsy of the tumor may be performed to confirm the diagnosis and determine the type of cells involved. While not strictly classified into subtypes, glucagonomas are often categorized based on their size, location within the pancreas, and whether they have spread to other organs. These factors influence the treatment options and overall prognosis. Tumors may be localized, meaning they are confined to the pancreas, or metastatic, indicating they have spread to other areas, such as the liver, lymph nodes, or bones. The extent of the disease plays a significant role in treatment planning. Treatment for glucagonoma focuses on controlling symptoms, reducing glucagon levels, and removing or shrinking the tumor. The primary treatment option, when possible, is surgical resection, meaning the surgical removal of the tumor. If surgery is not feasible, or if the tumor has spread, other treatments include somatostatin analogs, such as octreotide or lanreotide, which can help to lower glucagon levels and alleviate symptoms. Chemotherapy and targeted therapies may also be used to shrink the tumor and slow its growth. Medications to manage diabetes, nutritional support to address weight loss, and anticoagulants to prevent blood clots are important components of supportive care. Currently, there is no known way to completely prevent glucagonoma. Since most cases are sporadic, meaning they arise without a known cause, specific preventative measures are not available. However, individuals with a family history of MEN1 should undergo regular screening to detect any potential tumors early on. Maintaining a healthy lifestyle, including a balanced diet and regular exercise, may contribute to overall health and potentially reduce the risk of various cancers. Although a direct link to preventing glucagonoma has not been established, the prognosis for glucagonoma varies depending on several factors, including the stage of the disease at diagnosis, whether the tumor can be surgically removed, and the patient's overall health. If the tumor is localized and can be completely resected, the prognosis is generally good, with a 5-year survival rate exceeding 70%. However, if the tumor has spread to other organs, the prognosis is less favorable, with a 5-year survival rate ranging from 20% to 50%. Recent research is focusing on developing more effective targeted therapies and immunotherapies to improve outcomes for patients with advanced glucagonoma. Studies are also exploring the role of specific genetic mutations in tumor development to identify potential therapeutic targets. Continued research efforts hold promise for improving the management and outcomes of this rare and complex disease.